Welcome everyone. In this video, we'll be discussing a case. So I am sure that all of you would have seen the video that has preceded this case discussion. So in the video, we are discussing about a 64-year-old female who is a case of pneumonia. So we'll rediscuss the history, the examination, and try to see how to approach a case with suspected pneumonia. So the patient is a 64-year-old female. So that is the demographic details that are available. Apart from this, whenever you're taking a routine history, apart from the age, the other important demographic details that you should take while taking a good history would include the occupation of the patient, because especially in case of respiratory system, occupation plays a very important role because of the kind of exposures. There are a lot of occupational lung diseases as well as hypersensitive pneumonitis because of different exposures which might be relevant. So taking a detailed occupation history is extremely important. And apart from that, another history that you have to take includes the residence of the patient. So where does the patient live? Are there any factories surrounding the area? Are there any woods, any grasslands, any water bodies? Because again, a lot of different diseases can happen because of exposures. So these details about the demographics was missing, but should be there when you take a detailed history. The chief complaints of the patient was that the patient was having fever, cough, and hemoptysis, and all of these three symptoms were present for 2 days. So if you try localizing these symptoms of cough and hemoptysis, then definitely your localization will be to the respiratory system. Whenever we talk about the respiratory system, we always divide it into 4 compartments. The compartments are airway, then you can have parenchyma, then you can have pleura, and vascular. So whenever you're thinking of differentials or whenever you're exploring symptoms, then always see which compartment of the lung is involved, and accordingly your differentials will be narrowed. So when we talk about cough, then cough can be because of involvement of any of these 4 compartments. But when we talk about hemoptysis, that is blood in sputum, then the compartment that you would be talking about would either be airway, for example, like a bronchiectasis or a bronchogenic carcinoma, could be a parenchymal disease like an infection or a malignancy, or it could be a vascular problem like a pulmonary embolism or a vasculitis. Pleural diseases will not lead to hemoptysis. So with these 3 symptoms, I'm talking about the respiratory system, and we're talking either about an airway problem, a parenchymal problem, or a vascular problem. The second important clue that we have in the history is that the patient is having fever. So when we talk about fever, the group of diseases which will lead to fever could be either infections, or you can have autoimmune diseases which can also sometimes have fever, and rarely even malignancies can present with fever. And then the last clue that we have is all of these symptoms are present for a very short duration, that is only for 2 days. So whatever you're dealing with is an acute problem. So it's an acute disease. So therefore, if we combine all of this, then the most likely scenario on the basis of these chief complaints would be that the patient is having an infection, because autoimmune diseases and malignancies will have a longer duration of symptom, and an acute infection which is involving either the airway or the parenchyma is leading to a problem. Therefore, the most common differential that you will think of with these symptoms would be a lower respiratory tract infection, that is a pneumonia. Because the symptom duration is short, therefore the organisms that we will be thinking of will be bacterial and less likely to be mycobacterium tuberculosis or fungal infections. And because the patient is having hemoptysis, you will not think of viral. So you'll be thinking of a bacterial pneumonia. And as the patient is having hemoptysis, this means there is some amount of destruction happening in the parenchyma, which is leading to hemoptysis. Therefore, you're talking mostly about a necrotizing pneumonia. A normal pneumonia would not lead to hemoptysis. Whenever hemoptysis is there, you will think of necrotizing pneumonia. So on the basis of this chief complaints, my first impression would be that I am dealing with a necrotizing bacterial pneumonia. The other differentials in cases of infection, although symptom duration will not match, could be TB, could be invasive fungal infections if the risk factors are present. Again, these are unlikely in this scenario because the symptom duration is extremely short, but keep them in mind. Sometimes what can happen is that the patient will not give you the appropriate or the correct history. It might happen that the patient is having long-standing background symptoms but the patient is not coming forth with that history. The patient might be having some loss of weight, some loss of appetite, some low-grade fever, which the patient is not perceiving. So therefore, these differentials should also be there in your mind, thinking towards TB, especially in India, which is an endemic country, or fungal infections. Then, as we discussed, certain autoimmune diseases which can present like this in old age could be something like a GPA, that is granulomatous polyangiitis. Again, unlikely because of symptom duration, but symptoms of fever, cough, and hemoptysis for 2 to 3 weeks can be a presenting complaint for even GPA, and rarely even MPA, that is microscopic polyangiitis, which presents with diffuse alveolar hemorrhage. But again, in patients with DH, they will have more shortness of breath rather than hemoptysis and cough. But in GPA patients, where there are more nodules, more cavities in the lung, the patients can actually come forward with just fever, cough, and hemoptysis. Then, as we discussed, the next was malignancies. Again, malignancy in a female presenting with only 2 days history is again going to be extremely unlikely. But what can happen is that the patient is having a background malignancy, and now because of a superimposed infection, they are coming forward with these symptoms. Therefore, in the back of your head, you should also consider a possibility of a malignancy. So, our order of differentials would be first would be a necrotizing bacterial pneumonia. Lower down, we'll keep in our heads that TB, invasive fungal infections, if risk factors are present, GPA, and even a malignancy, we'll keep them lower down. Now, let's come to the history of presenting illness. So, talking about the history of fever, the patient has come with high-grade fever with chills and rigors for 2 days with no diurnal variation or rashes. Coming to the history of cough, the cough is present for 2 days with blood-tinged sputum. So, whenever the patient is coming to you with complaints of hemoptysis, what is important is to ensure or to make sure that the blood is actually coming from the respiratory tract, that it is the true hemoptysis and it is not pseudo hemoptysis. So, what do you understand by pseudo hemoptysis? Is that the blood is actually coming from some other place. For example, the patient might be having an ENT bleed, that is a nasal bleed epistaxis, and now the patient is spitting out blood and feeling that it is hemoptysis, or the patient might be having an upper GI bleed, which the patient is perceiving as blood coming out from the mouth or hemoptysis. This will commonly happen in the emergencies when the patient is coming to you with complaints of bleeding from mouth and the patient is perceiving it as hemoptysis. So therefore, whenever the patient has hemoptysis, take negative history for nasal bleeds as well as upper GI bleeds. So here we have taken a negative history that the patient does not have any epistaxis, the patient does not have any melena, and therefore we are sure that we are dealing with a hemoptysis. The next thing is quantification of the hemoptysis. So for quantification, usually we ask questions like what is the amount of blood in terms of teaspoons or in terms of cups of blood that the patient might have expectorated. Along with this, when we want to ask history about massive hemoptysis, then in massive hemoptysis, we take history for episodes of syncope. So if an hemoptysis was associated with syncope, this means it was a massive hemoptysis. Also, if the hemoptysis was significant, then the patient's airways will be filled with blood, and therefore the patient will have symptoms like chest tightness and choking sensation. So this negative history is important to quantify the hemoptysis apart from using measures like teaspoons or cups of blood. Then the patient did not give any history of chest pain, loss of weight, loss of appetite, or shortness of breath. Therefore, there was no background history of prolonged fever, prolonged loss of weight, loss of appetite, making tuberculosis or malignancy a less likely differential in our scenario. The patient is not having shortness of breath, which means that again a diffuse parenchymal process is unlikely, and it's mostly a focal process, because if it's a diffuse process, the patient will be having shortness of breath. Therefore, possibility of diffuse alveolar hemorrhage is again unlikely. Then the patient does not complain of any other systemic symptoms. So it is a very general line that has been written, but you need to ask specific history related to the cardiovascular system, related to the CNS, related to important history, negative history of vasculitis, like if the patient is having joint pains, rashes, neuropathy symptoms, eye symptoms of uveitis, or the patient is having renal symptoms, because most of these DH patients will be having pulmonary renal syndrome. So taking history for hematuria, decrease in output, pedal edema, again becomes extremely important. Along with this, a lot of your bacterial pneumonias, a lot of those species can present with systemic symptoms as well. For example, if we talk about Legionella, then you know that Legionella patients can present with hyponatremia, and because of hyponatremia, they might be having vomiting or be confused. The patients can also have cerebellar ataxia. When we talk about mycoplasma, Then patients who have mycoplasma pneumonia can also have cold agglutinin disease. Therefore, they can complain of cyanosis and Raynaud's like phenomena, or they can also have encephalitis like symptoms or neuropathy like symptoms. So again, this becomes important. Other negative history that needs to be taken in this would be if the patient was having any preceding upper respiratory tract symptoms, like the patient was having nasal discharge, sore throat, or if other members in the patient's family were also having similar symptoms. If there are a lot of URTI symptoms, family history is present of an infection, then you start thinking more towards a viral infection. And if the patient has that preceding history of a viral infection and now is coming with recurrence of fever, cough, and hemoptysis, then you start thinking that the patient might be having an influenza like illness before, and now has developed a super infection which has led to hemoptysis. Therefore, taking this history of URTI like symptoms and family history also becomes important. Coming to the past history of this patient gave history of diabetes. Although the control of diabetes was not mentioned, it is very important to explore what is the control of diabetes, because if the diabetes is uncontrolled, the HbA1c is more, then you start thinking more towards fungal infections and TB. So in patients with uncontrolled blood sugars, the patients who come with diabetic ketoacidosis, mucormycosis is commonly seen, in even invasive aspergillosis seen. If the diabetes is controlled, then I will not be thinking towards those fungal infections. Then hypertension. Then the patient also gives history of CAD and is a post PTCA status. Why is this important? Is because if the patient is giving a history of CAD and is post PTCA, then definitely the patient would be on some form of antiplatelet drugs. Again, antiplatelet drugs could be the sole reason why the patient is having hemoptysis. Therefore, it's important to take history if the patient is having bleeding from any other site, if the patient is having hematuria or any melena or any epistaxis or any gum bleeds when the patient is brushing, or if the patient is having any kind of a purpura rash. So if any of these symptoms are present, then you start thinking more towards a drug-induced bleeding cause rather than a primary pulmonary cause. The patient did not have any surgical history as mentioned. One important past history that was mentioned in the video was that the patient was having history of hospitalization twice in the last 3 months for similar complaints. This means that the patient is having similar symptoms multiple times over the course of 3 months, and the patient was treated with IV antibiotics each time and was discharged. Prior to those 3 months, the patient did not have any respiratory illness. So this is a very important clue for us. What does this suggest? That there is some problem that is ongoing for 3 months. So there can be two possibilities. First possibility can be that the problem is a single problem which is being partially treated with antibiotics, and once the effect of antibiotics wear off, the problem is coming back. So it is a partially treated problem. So I can start thinking the patient might be having an infection like a tubercular infection, and because a lot of antibiotics that we use like meropenem, levofloxacin, augmentin, etc., can also have some form of anti-tubercular activity. Therefore, with the use of this antibiotics, the infection is only slightly getting better, and once the antibiotics are stopped, the patient's again coming back with recurrence of symptoms. That is one way to think. The second possibility can be that the patient is having risk factors for recurrent infections. These risk factors could be systemic factors or they could be local factors. So for systemic factors, maybe the patient's blood sugar is very poorly controlled, because of which the patient's immunity is less and he's having recurrent infections, or the patient is having a retroviral disease, or local factors. This means there is some problem locally in the lung, because of which there is mucus accumulation, bacterial colonization, and recurrent infections happening. So I start thinking whether the patient is having a bronchiectasis and the patient is getting recurrently infected, or there can be a focal bronchiectasis which is getting recurrently infected, and that part of the lung keeps on developing pneumonia. And then we start thinking towards the causes of focal bronchiectasis, like maybe a tumor compressing the bronchus, or an aspiration of a foreign body, or an endobronchial obstruction or endobronchial tumor. So all these things should be there in the back of your head if you see a history that the patient is having multiple episodes of pneumonia. Coming to the personal history, the patient is a non-smoker. Again, a female who's a non-smoker. So with non-smoking, your probability the patient is having malignancy goes down. There is no history of alcohol intake. Why alcohol intake becomes important in your history is because if the patient has significant history of alcohol intake, Then you need to inquire if the patient has episodes of unconsciousness following alcohol intake. If that is present, you start thinking towards possibility of aspiration pneumonia. Again, aspiration pneumonia could be a cause for formation of a lung abscess, and the lung abscess can present with complaints of fever, cough, and hemoptysis. Then the patient's bowel and bladder habits were normal, and sleep and appetite were also normal. Now, coming to the examination. So, on the examination, it was said that the patient was alert, conscious, and oriented. This becomes important because we are talking about a possibility of pneumonia. Whenever you talk about the severity of pneumonia, confusion is one very important sign that we see. If confusion is present, then this means that the pneumonia is severe. Next, the patient's heart rate was 108 per minute. So the patient was tachycardic. The blood pressure was normal. The respiratory rate was slightly high. It was more than 24. The saturation was normal, although slightly on the lower end of normal. And the patient was still febrile. There were no pallor, icterus, sinuses, clubbing, lymphadenopathy, or edema. So it's important to look for all of these signs. If the patient is having lymphadenopathy, then you start thinking towards more like a tubercular infection. You're not expecting lymphadenopathy in a patient with a bacterial pneumonia. Coming to the examination, so in the respiratory system examination, it was said that the inspection, palpation, and percussion were normal. There was no abnormality detected. And when we talked about auscultation, then in the video it was said that there were bronchial breath sounds heard over the right infrascapular region. And along with that, there were presence of biphasic coarse crepitations. So let us discuss what are the examination findings of pneumonia. So when we talk about pneumonia, that is when we're talking about lung consolidation. The examination findings, when we talk about auscultation, would be that the patient will be having bronchial breath sounds. So we know bronchial breath sounds could be of three types. They could be tubular, amphoric, or cavernous. So when we talk about consolidations, then the type of bronchial breath sounds that we get is a tubular bronchial breath sound. Along with this, we also have certain added phenomena, like the patients can be having egophony. That is, if the patient is asked to speak E, what you hear is A. And then along with this, you can have bronchophony. Then what you can have is whispering pectorally. Again, along with this, you can have an increased vocal resonance and an increased vocal fremitus. So all of this happens because the conduction of sound is improved as the lung solidifies and there's a consolidation. So you'll have tubular bronchial breath sounds, egophony, bronchophony, whispering pectorally, as well as increased vocal resonance and vocal fremitus. Your inspection findings will be roughly normal. Your percussion can be mildly dull. So all of these findings will suggest that you're dealing with a consolidation. Then when a systemic examination was done for this patient, the systemic examination in the abdomen, the CNS, and the CVS were all normal. So with this, what are the differentials that we have in our mind? So as we spoke on history, we are thinking the first differential that we are thinking towards was a pneumonia. So the positive findings that we got on a history examination suggested a consolidation in the right lower lobe because the bronchial breath sounds are present in the right infrascapular region, which again points towards the pneumonia. The patient was not having any history suggestive of vasculitis like symptoms. No long-standing history was present of loss of weight, loss of appetite. So therefore, the first differential that we are thinking towards is a bacterial pneumonia. But because the patient is having similar episodes over the last 3 months, therefore, in the back of my head, I'm also thinking towards a chronic infection like a TB or a fungal infection like a mucormycosis, the patient, because the patient is diabetic. We are not sure about the diabetic control. And also, I'm thinking if there is a local problem like a bronchiectasis or a problem in the bronchus and obstruction of the bronchus, which is leading to recurrent pneumonias in the patient. So these are the differentials that I'm thinking towards. First is TB, bacterial pneumonia. Then I'm thinking towards on the back of the mind, TB as well as mucormycosis. And I'm thinking if there is a local problem like a bronchiectasis, a focal bronchiectasis, or a bronchial obstruction. With the history that we are taken and the examination, you you are kind of sure that you're not dealing with a malignancy or you're not dealing with an autoimmune disease like a vasculitis. So coming to the radiology that is this patient had. So I'm sorry that the quality of the images is poor that I was given. So if we look at the X-ray or the topograph of the CT, then this coronal section, you can see that the left side appears to be roughly normal. If you see the right side, then there is silhouetting of the diaphragm medially as well as slitting of the right heart border, and there is some opacity, homogeneous opacity that can be seen in the right lower zone. Similarly, if we see the coronal section of the CT, then I can see I'm not able to clearly delineate the diaphragm or the right heart border. This means that there is some problem in the right lower lobe, and also I can see the presence of air bronchograms. So what I'm seeing here is a right lower zone consolidation. Coming to the axial images. So in these axial images, if we see, I can see that the upper lobes are normal. The upper lobes are normal. Coming slowly down, then I can see this homogeneous white opacity that can be seen in the right lower lobe. In the CT, we like to talk about segments. So as you can see, this is the horizontal fissure that is seen, and this consolidation is just below it. This consolidation is involving the right lower lobe. It is involving the superior segment of the right lower lobe, which is also known as. And we can also see the presence of these air bronchograms. So what you are seeing is a dense consolidation of the right lower lobe. If we try to trace the airway to look for any endobronchial obstruction, then I'm able to trace the right mainstem bronchus, the right intermediate bronchus, and then even the right lower lobe bronchus can be seen patent. Therefore, there is no endobronchial obstruction that is present. Again, when we see a scan and we see an infection, we want to differentiate what kind of an infection it is, whether it's a bacterial infection, a viral infection, or a fungal infection. So I'll just show you some common patterns that can be seen. So if we talk about this kind of a presentation, so what you are seeing in this CT is that you're seeing a lot of ground glassing that is present. The problem is bilateral. There's a lot of ground glassing. This whitish shadows where the background in vasculature can be seen is known as ground glass. So there's a lot of ground glass. It is bilateral. It is subpleural, and this is suggestive of a viral pneumonia. Viral pneumonia or an atypical pneumonia, which could be because of chlamydia, legionella, or mycoplasma. So a viral pneumonia, atypical pneumonia would be bilateral. It will be more diffuse, subpleural with a lot of GGOs. A lot of you would have commonly seen this kind of CT scans during COVID-19. Then if we talk about the second pattern, then as we see, the problem here is focal. It is not bilateral. What you're seeing is small nodules that are present in a tree in bud fashion. So these are known as centrilobular nodules. These are known as centrilobular nodules in a tree in bud fashion. So when we have centrilobular nodules in a tree in bud fashion, we start thinking towards endobronchial infections. That is, the infection is spread by the endobronchial route. And in this, we start thinking towards tubercular infections, or we think towards aspiration pneumonia. So this is how commonly your CTs of tubercular patients look like. They have a lot of centrilobular nodules. Along with that, they can definitely have cavities and consolidations as well. Coming to the next pattern, then if we talk about the first CT on the left, then the pattern that can be seen here is known as the reverse halo sign. So what do you understand the term reverse halo? So reverse halo means that the patient will be having ground glass or cavitation in the center, and around it, what you're having is a consolidation. So as you can see, you have a consolidation that is dense white opacification at the edges, and this center, what you're seeing is cavitation and ground glass, that is haziness. So this kind of a pattern is known as reverse halo sign, and it's also known as a bird nest sign. So when you find a bird nest sign or a reverse halo sign on CT, then you start thinking towards fungal infections. And in fungal infections, the bird nest sign is usually or commonly seen in patients with mucormycosis. Again, these signs are not pathognomic or 100% specific for a particular disease, but they are commonly seen in patients with mucormycosis. If we talk about this CT, then what you can see is you can see a dense consolidation in the center, and at the periphery, what you're seeing is a lot of ground glass. So consolidation in the center and a lot of ground glass at the periphery is what is known as a halo sign. So when you have halo sign, you start thinking towards an invasive fungal infection. That is, you start thinking towards aspergillosis. So the reason these signs appear is because fungal infections are invasive infections. The fungus invades the blood vessels, and once it starts invading the blood vessels, it leads to hemorrhage around the areas, and this hemorrhage is what appears like ground glass. So this kind of a CT picture, you should start thinking of invasive aspergillosis. And when we talk about bacterial pneumonias, then that was similar to the CT that we saw. The patients in bacterial pneumonias, the patients will be having dense lobar consolidations. The patients will be having dense lobar consolidation. Along with this, sometimes even in patients with bacterial pneumonia, you can sometimes have bilateral disease. That usually happens if the patient is having a gram-negative bacteremia or sepsis. So when the patients have a gram-negative bacteremia or a gram-negative infection like E. coli, Klebsiella, etc., then the patients can have bilateral multilobar consolidations or necrotizing pneumonia. When we talk about the usual community-acquired infections like streptococcus, or we talk about Haemophilus, then what we usually get is just a unilobar consolidation. Certain bacterial organisms can also have certain specific features on CT. For example, if we talk about Staphylococcus or if we talk about Klebsiella, then sometimes what you can see is the presence of pneumatoceles in these patients. Pneumatoceles. So what are pneumatoceles? Pneumatoceles are air-filled, thin-lined cysts that can be present. Usually these occur in the second week of illness. When the patient is first coming, what you will see would be lobar consolidations. So on the basis of these, what we have just learned, so the CT of our patient actually fits more into a bacterial pneumonia because it is a dense lobar consolidation. There are no nodules, there is no GGO, there is no endobronchial obstruction, and it's a unilateral problem. So again, whenever you're reading your imaging, your X-ray or your CT, try to see if any of these findings are present because this will help narrow your differentials down. So if you have a cavity that is present, then you are thinking more towards a necrotizing pneumonia, a TB or a fungal infection. Viral infections will not lead to cavitations, or a simple community-acquired strep or Haemophilus or an atypical pneumonia again will not lead to cavitation. Then if we're seeing a lot of presence of nodules, so when we have a lot of nodules, you start thinking towards endobronchial infections, you start thinking towards TB, or you think towards aspiration, or you can also think towards an airway invasive aspergillosis. An airway invasive aspergillosis. Then if the patient is having pleural effusion or not. So this is a very important marker. If the patient is having pleural effusion along with a pneumonia, then the common organisms that will present with the pleural effusion would either be a bacterial infection or it will be a tubercular infection. When we talk about fungal infections and viral infections, they are not associated with effusions. Then if the patient is having nodes on the CT, if there are significantly enlarged nodes, again you start thinking more towards TB. Fungal infections, viral infections and bacterial infections are usually not present with nodes in the mediastinum. Then whenever the patient is having any kind of pneumonia, always look for the bronchus and see if there is any endobronchial involvement. In our patient, we were able to trace the bronchus, therefore we were sure there is no endobronchial obstruction. Then if the problem is unilateral or bilateral, as I told you, viral infections, atypical infections would usually be bilateral. Mucormycosis, bacterial infections would usually be unilateral, and looking at the zonal predominance. So if it is an upper lobe predominant disease, you think towards tubercular. If it's involving just the lower lobe, you think towards aspiration pneumonia. So this is how your zonal if it's a middle lobe involvement, again you start thinking towards aspiration pneumonia happening when the patient is supine, etc. If this patient is having a long-standing history, has nodules predominantly in the middle lobes, then you start thinking towards NTM as well, Lady Wintermere syndrome, etc. So this is how your radiology will guide you to narrow your differentials down when you're dealing with a pneumonia. The next question that we had is, what are the other investigations that need to be ordered? So in the video, no other investigations were ordered for a patient, but I'm just telling you what you should do when you're having a patient with pneumonia to your OPDs or to your inpatients. So the guidelines say that if a patient is coming to you with pneumonia, if the pneumonia is non-severe, that is, it is an OPD patient, you think that the patient can be managed in an outpatient setting. So the pneumonia is non-severe or the pneumonia is severe. So if the pneumonia is non-severe, then actually no investigations is needed for microbiologic testing. Microbiologic testing is usually not indicated in patients with non-severe pneumonia. There is no point of sending a gram stain or a sputum culture or doing urinary testing because patients would respond to empirical treatment most often than not. The only test that is recommended for a non-severe pneumonia would be to test for influenza or COVID-19 if it is prevalent in that setting or in that season. So you can test for influenza or COVID-19 if it is relevant according to the season and according to your setting. Other investigations or other microbiological testing is not needed. But if the patient is having a severe pneumonia, then you are supposed to send a sputum gram stain, a sputum bacterial culture. You're supposed to send a blood culture. You do a urinary testing. You do a urinary testing for Legionella. You do it for Streptococcus pneumoniae. And along with this, obviously, you will be testing for influenza and COVID if the setting is right. Also, if the patient is having risk factors for MDR organisms, if there are risk factors for MDR, then you should always send a sputum gram stain culture, irrespective whether the pneumonia is non-severe or severe. Now, once you have diagnosed the patient as having a bacterial pneumonia, then it is very important before you start management to sub-classify the pneumonia according to its severity. So severity assessment of pneumonia is very important. It helps you decide the initial management and also helps you decide where the patient should be managed, as an outpatient, as an inpatient, in the ward or in the ICU. So a lot of scores that are relevant to pneumonia, the important ones that you should be aware for your clinics and also for your exams would be the Curve 65 score, which is the most commonly used score. The Curve 65 C stands for confusion. U stands for a BUN, that is a blood urine nitrogen level of more than 19. R stands for respiratory rate of more than 30. This cutoff is important. B stands for blood pressure, that is an SBP of less than 90 or a diastolic blood pressure of less than 60, and then an age of more than 65. So all of these points is given a score of 1. So therefore, it is a total score of 5. Now, if the patient is having a score of 1, 0 or 1, then the patient is low risk and can be managed at home. If the patient is having a score of 2, then the patient can be managed at home or can be managed in the hospital. It has to be a discussion between the clinician and the patient. So it could be a short inpatient or closely supervised outpatient treatment. If the score is 3 or above, then the patient definitely needs inpatient management. If the patient is having a score of 4 or 5, the patient directly goes to ICU. If the patient is having a score of 3, then the patient can be managed either in the ward or in the ICU. So it is according, again, a discussion depending on the patient factors. The next score that you should know is the PSI score, that is the Pneumonia Severity Index. So pneumonia severity index is a score that has a lot of variables. It is not possible for you to remember all of those variables. What you need to understand is on the basis of the value of those variables, the patient is sub-classified into 5 classes of PSI: class 1, class 2, class 3, class 4, and class 5. And so if the patient is in class 1 or 2, the patient is considered to be low risk. If the patient falls into PSI class 3, 4, or 5, that is relatively higher risk and the patient needs admission. So class 3 and above need to be admitted, and class 4 and 5, the risk is more and the patient should be going to the ICU, right? So class 5 goes to ICU, class 4 and 5 goes to ICU, class 3 gets admitted, and class 1 and 2 gets managed at the outpatient basis. So this is the pneumonia severity index that you should know. One of the newer indices that has come to that has been used recently for classifying pneumonia is the SMART COP index. So again, each of these letters stands for one variable. So if you look at the SMART COP index, S stands for the systolic blood pressure, M stands for the involvement of the X-ray, whether it's a unilobar or a multilobar involvement, A stands for the age, then you have the respiratory rate, you have the temperature, you have confusion, you have the oxygen levels, and then you have the pH. I'm sorry, A here stands for albumin levels. So two additional variables that are present in the SMART COP index but is not present in the curve 65 score would be P, that is pH, and A, that is albumin. So pH and albumin are two additional factors that are present in the SMART COP index. So sometimes you will not be having the pH or you will not be having the albumin levels initially. Therefore, curve 65 or the pneumonia severity index is what is most commonly used to decide regarding the patient management. Now coming to the treatment guidelines. So in our patient, what the patient received was actually piperacillin, tazobactam and teicoplanin. Let us see if that management was appropriate for the patient or not. So if we talk about the ITSA guidelines for treatment of CAP, then the guidelines can be divided into two categories, whether it's an outpatient management or it's an inpatient management. Let's first talk about outpatient management. So in outpatient management, what ITSA says is that subclassify whether the patient is having any comorbidities or risk factors for antibiotic resistance. If the patient is not having any comorbidities, as the most structural lung disease like COPD, asthma, ILD, bronchitis, there is no chronic liver disease, no diabetes, no chronic kidney disease, no chronic heart disease, therefore there is no significant comorbidities, then it suggests that you can get away by only either giving amoxicillin or by just a monotherapy with a macrolide if the macrolide resistance is low. So if there are no comorbidities, there are no risk factors, it is an outpatient, it's a non-severe pneumonia, then either just give amoxicillin or you can just give a macrolide. On the other hand, if the patient has comorbidities like a structural lung disease, diabetes, CKD, chronic heart failure, etc., then you have to give a combination therapy of a beta-lactam plus beta-lactamase inhibitor like amoxiclav along with the macrolide. So what you commonly give is amoxicillin clavinate acid plus azithromycin, or you can give a monotherapy with a respiratory fluoroquinolone like a levofloxacin or a moxifloxacin. So this is what it needs to be given if the patient is having comorbidities. Now next, coming to if the patient gets admitted or it's an inpatient. So if it's an inpatient, you again classify whether it's a non-severe disease or it's a severe disease. By severe disease, you mean the patient is in sepsis or the patient is in shock or the patient is requiring high amounts of oxygen or the patient is intubated or mechanical ventilation. All these will be severe disease. Everything else would be a non-severe disease. So if you have non-severe disease, then you see if there are any MDR risk factors present or not. What are the MDR risk factors? The only important MDR risk factors that are now recognized is if the patient has been hospitalized in the last 3 months and has received parenteral antibiotics in the last 3 months. So if it is in less than 90 days, the patient has received parenteral antibiotics or has been hospitalized, then that is considered as a risk factor for MDR. So if the patient does not have any risk factors for MDR and is having a non-severe disease, then what you give is a beta-lactam plus beta-lactamase inhibitor along with a macrolide, or you give just a respiratory fluoroquinolone. If the patient has risk factors for MDR organisms, but it is a non-severe disease, then you again start with the same treatment of azithromycin plus amoxiclav or a respiratory fluoroquinolone, but you send samples for MDR organisms. You send a sputum culture report and you wait for the culture report. Because the patient is non-severe, therefore you can wait for the culture reports to come. So you add coverage for MRSA or you add coverage for Pseudomonas only if the cultures are positive. Otherwise, you just treat with a beta-lactam plus a macrolide combination. On the other hand, if the patient is having a severe disease, then if there are no risk factors, the treatment remains same. But if there are risk factors for MDR organisms like hospitalization or antibiotic treatment, then you have to empirically treat the patient for MDR organisms. Therefore, you empirically add coverage for MRSA. The coverage could be in the form of either vancomycin, teicoplanin, or linezolid, and you also treat the patient for Pseudomonas aeruginosa with using of drugs like piperacillin, tazobactam, or carbapenems like meropenem, imipenem, etc. So in our patient, in this scenario that we just saw, the patient was having recurrent history of admissions to the hospital and receiving IV antibiotics. The patient was old age, was having tachycardia, tachypnea, borderline saturation. Therefore, she was falling into the inpatient category, and therefore this must be the reason why the patient was started empirically on teicoplanin as well as on piperacillin tazobactam in order to cover for both MRSA as well as Pseudomonas aeruginosa. Another one thing that we should discuss while talking about the treatment for community-acquired pneumonia is if the patient is having, what is the role of steroids in community-acquired pneumonia? So for a very long time, some people were using steroids to treat pneumonia along with antibiotics, whereas another school of thought was that the use of steroids could be actually detrimental. So recently, there was a very large study that was known as the CAPE COD trial. So the CAPE COD trial actually showed that the use of corticosteroids in patients with severe pneumonia is actually helpful. It reduces mortality and also reduces the risk for intubation. So which patients should be given steroids if they have community-acquired pneumonia? Then only patients who are having a severe pneumonia should be given steroids. So a severe CAP patient, and severe CAP should be defined if the patient is having a pneumonia severity index of class 5. That is a score of more than 130 points. Or if the patient is requiring invasive mechanical ventilation, or if the patient is requiring high flow nasal oxygen with an FiO2 requirement of more than 50%. If any of these things are present, then the patient would be said to have severe pneumonia. And in these patients, there is a role for adjunctive glucocorticoids. What this trial used was hydrocortisone. They use hydrocortisone in a dose of 200 mg per day, and they actually use it for 7 to 10 days. The duration actually depended upon the response. The minimum duration that they use it for was for 7 days. So again, please do not use glucocorticoids in all your patients with CAP. Only use if the patient is having severe CAP, and again, a short duration of glucocorticoids. One thing that you should remember before administering glucocorticoids is be sure that you're treating a bacterial pneumonia. Do not use glucocorticoids if the patient is having an influenza pneumonia, because previous studies has shown that the use of glucocorticoids in patients with influenza pneumonia can actually increase mortality. Also, obviously, you will not be using glucocorticoids if you have a high degree of suspicion for mucormycosis, fungal infection, or tubercular infections. Lastly, suppose you have started treatment for the patient, you know it's a bacterial pneumonia, you have started the appropriate antibiotics. Now, what if the patient does not improve? Usually, what we see is that once the correct treatment is started, then the patient starts improving within 24 to 48 hours. Usually, within 48 hours, the fever goes away. Then, slowly and steadily, the patient's oxygen requirement goes away. The patient's leukocytosis settles. The CRP levels go down. The cough settles slowly. But radiographic clearance can take time. Radiology can actually, it lags behind clinical resolution. The X-ray can continue showing an opacity for 3 to 4 weeks, but the patient's clinical factors improve within 2 to 3 days. So if the patient is not improving, then what are the things that we should think about? So firstly, you should recheck your diagnosis, whether the diagnosis of bacterial pneumonia was correct or not. What if the patient was actually having TB, or the patient is having an invasive fungal infection, or rarely the patient is having a vasculitis or a lung mass? In our situation, because the CT was very typical, so we will not be thinking towards these things, but this should be there if your patient is not improving. Second, are you using the correct antibiotics or not? When the patient is having an MDR organism, but you're not using MDR antibiotics, or the patient is having a XDR organism, therefore revisit your antibiotics, send your cultures, discuss with your microbiologist, see if there was any previous sputum culture available with the patient, see which antibiotic the patient responded previously to and use the same ones. So recheck your diagnosis and recheck the antibiotics that you're given. Lastly, also see if the patient is having pleural effusion. So bacterial infections or bacterial pneumonias can be associated with synpneumonic infusions, which are known as parapneumonic effusions. These parapneumonic effusions could be uncomplicated, that is simple infusions, or they could be complicated infusions where the infusion itself is infected. So if the patient is having a complicated parapneumonic effusion, then until unless you drain the effusion, just giving antibiotics will not be sufficient. The patient will continue to remain symptomatic. So if a patient is not improving, always reorder an X-ray or reorder an ultrasound chest and try to see if there is any effusion. If the effusion is more than 1 centimeter, then do a diagnostic tap, see whether it's an uncomplicated or a complicated effusion, what if it's an empyema, and then treat it appropriately. So always think of these things when your patient is not improving. Fortunately, in our case, when the patient was given piperacillin tazobactam and teicoplanin, the patient responded over 2 to 3 days, and ultimately the patient was being able to discharge. Lastly, the thing that I would like to discuss is the duration of antibiotics. So when we talk about CAP, the minimum duration that the antibiotic should be given is 5 days. That is minimum 5 days. But what is recommended is that the antibiotic should be continued at least after 48 hours of clinical resolution of symptoms. So once the fever goes away, the leukocytosis settles, the patient starts improving, then you should continue the antibiotics for an additional 48 hours. So either 48 hours after clinical resolution of symptoms or a minimum of 5 days, whichever is longer, should be the appropriate duration of antibiotics. So this is all that I wanted to discuss about this case of pneumonia. So I've tried to cover history, examination, also giving you some important clinical pointers, a bit about the treatment, so that now whenever you see a patient of pneumonia in your OPDs or in your inpatient clinics, you know what all needs to be done. Thank you.